that all adverse food reactions are not food allergy. They can be aversions, they can be intolerance or so. Food allergy refers specifically to the reactions which are caused by the protein substance in the food leading to an allergic reaction. And allergic reactions could be IgE or non-IgE mediated, and sometimes they can be a mix of them. So combination of IgE and cell mediated are also known to occur. And I'll go into the classification as the talk goes. Now, the most common foods, if you look across any data, are these top 8 foods across the world. So they include milk, eggs, soy, wheat, fish, shellfish, peanuts, and tree nuts. So these are the top 8 culprits which are there throughout the world. Uh, Although we do understand that there would be a lot of geographical variations which occur. So, for example, if you look at the Western world, so whole of Europe, US, Canada, and Australia, so they have a lot of allergy to peanuts and tree nuts, uh, and the rest of the things follow. If you look at mainly the Asian perspective and the Indian subcontinent, then the allergy to peanuts and tree nuts is significantly low, right? And a lot of people would say that they have not seen any child with peanut or tree nut allergy. So in India, it is mainly the other things which are important. So milk is definitely the first thing. Eggs, wheat is quite common. Soy, and definitely seafood like fish, shellfish. Uh, the peanuts and tree nuts, we need to know that uh, peanut is actually not a nut but a legume. Uh, and quite common in the Western world. There are reasons why it is not seen in India. Then tree nuts include things like cashews, almonds, hazelnut, macadamia, walnut, pistachio, and so on. So some of these nuts are not very commonly used in India, but there are definitely a few of them which are rampantly used, like almond, cashew, and pistachio. So these are the common, and walnut. So these are things which are commonly used in India as well. Rest of the things are not as common. Uh, Now, in addition, what we also see in the Asian population and in India is allergy to legumes. So, peanut, as I said, is a legume. Then you have soybean, chickpeas, lentil, peas, and beans. So these are all legumes, and allergy to legumes is specifically seen in the Indian setup, and all these legumes are known to cause allergic issues. So it might be things like arad dal, tur dal. It might be red beans, mixed bean, moong dal. So all these things are described to cause food allergies in India. Now, in addition, there can be allergy to fruits as well, although not very common. Uh, all fruits are known to cause allergies. The most common which has been reported is banana and kiwi. So these are the two most common foods, but rest of the foods also have been known to cause allergies in children. Now, allergies have been known to be increasing throughout the world, and definitely there has been something like a pandemic in the Western world, and their figures are very high. So last year when I went to St. Mary's in UK, every second or third child would in the OPD has a nut allergy, right? So it is as common, right? And their figures have really increased by 3 or 4 times from somewhere like 1998 to 2018. So in around 20 years, the allergies have significantly increased, and food allergies are very common in the Western world. In Indian setup, they are definitely increasing, but not as much. Now, there are reasons why food allergy is possibly thought to be increasing. So one is a hygiene hypothesis that as the hygiene improves, there's less of or change of the microbiota and uh, less of infections, and it leads to more of allergies. And there have been mechanisms described how. Uh, there have been other reasons like delayed versus early introduction of allergic foods such as eggs, peanuts, and tree nuts. Now, just to understand this point better, why India does not have a lot of peanut allergy or tree nut allergy as compared to the Western world is because possibly in India and in some other countries, these nuts are introduced quite early. So there's a large study which is known as a LEAP trial, which was done from the Evelina's Children's Hospital in UK, where they randomized patients into early introduction of peanut in the form of peanut butter in infancy versus late introduction of peanut. So what they found was that the incidence of peanut allergy was significantly higher in children who got peanut later. So the all the guidelines, if you read the American or the Australian guidelines, now recommend that these foods actually should be introduced early into the child's diet to reduce food allergies in children. So we have good data for peanut, and there is some data for eggs. We do not have data for the other nuts or foods. Then it also depends on food processing, such as roasting of peanuts, which is making them more allergenic than boiling. Uh, there's also some data on the development of allergy to food by topical skin exposure because of the refined oil-based moisturizers which are used, change in microbiota, and their epigenetic changes which have been reported. Now, once you have a food allergy in the context, then how do we diagnose it? So basically, the most important step, the first step is the patient's clinical history. If the history fits into that, then you have to determine that there is a sensitization of food, and there comes the role of allergy testing. But there is also an important role of elimination diets for diagnostic purposes. So this is for diagnosis and not for treatment of confirmed food allergy. And the last and a very important step is an oral food challenge, which we'll talk about. Now, the most important is the patient's clinical history, and we have to know that food allergies could be IgE or non-IgE mediated, or they can be mixed. So IgE mediated disorders could be immediate GI hypersensitivity. It can be pollen-associated food allergy syndrome, and I'll talk about it. It can be an anaphylaxis, or it can be a food-induced, exercise-induced anaphylaxis, and I'll try and clarify these terms as the talk goes. Then non-IgE disorders are also known like food protein-induced enterocolitis syndrome, allergic proctocolitis, which we see quite commonly with milk allergy, and food protein-induced enteropathies. So these are the three common things which are seen uh, in the non-IgE variety. Then there can be mixed varieties like eosinophilic esophagitis, gastritis, uh, gastroenteritis, colitis, and atopic dermatitis. So these are the mixed varieties which are seen. So atopic dermatitis is known to be associated with some food allergies like milk allergy, egg, and soy. So these are the common things where atopic dermatitis can be associated with food allergies. Now, these are the phenotypes which are associated with food allergies, and we are talking about IgE mediated allergies in these phenotypes. So there could be a classical phenotype which could then be classified as transient, persistent. So transient is associated with things like milk, egg, and wheat. So that is what is there in this figure: egg, milk, and wheat. So it is called as transient because most children would gradually wean off these allergies, and only about 10 to 15% would carry on these allergies into adolescence and adulthood, right? So these are mostly described as transient allergies. Now, on the other hand, there is a persistent variety which is seen with nuts or peanuts, tree nuts, fish, or shellfish. So most of these children will not go off these allergies and would continue to have these allergies into adolescent and adulthood. The third phenotype which is seen is which is called as FDEIA, or food dependent exercise induced anaphylaxis, where anaphylaxis is seen only when the child consumes a particular food and then he exercises. It is not seen if the food is taken without exercise or exercise is done without the food. So that is a entity which is described and most commonly associated with wheat. But now there are case reports that food-dependent exercise-induced anaphylaxis could be associated with other foods as well. Then it could be NSAID dependent or alcohol dependent in older children or adults, where the NSAIDs or alcohol is actually a cofactor which increases the chances of allergy in that particular child. Now, there can be intermittent or cross-reactive variety where actually you find that the child is allergic to one thing but is cross-reacting to the other because the protein moieties are similar. So that is what is meant by cross-reactivity in food allergens, and it is important to know because once you know that the child is allergic to one particular food, then we have to know that what rest foods could be safely given to a particular child. Now, the third is something known as aerosol sensitization, where there can be because of the pollens. So, which means that a child is sensitized, for example, to a particular food allergen, but that food allergen actually cross reacts with the pollen. Now, when the child is exposed to the particular food, then the child would get symptoms, right? And there's a slide on pollen food allergy syndrome, which I'll come to. There's an also entity where the child can get anaphylaxis or a bad allergic reaction when the child gets exposed to aerosolized food. So, for example, a child who's allergic to milk enters Costa coffee, and the child suddenly develops an anaphylaxis without even having a sip of the coffee. So, because there are particles of milk in the air, because so when they make coffee, they would froth the milk, and there are a lot of incidents reported that the child develops anaphylaxis because the child actually inhales some particle of milk. So this is also a well described entity. Then there's something known as an alpha-gal syndrome, and then there's an entity known as sensitized non-reactive, which means that you get sensitization when you do a skin testing or allergy testing, but the child still does not manifest the clinical symptoms. So IgE-mediated food allergy can have skin manifestations, so the child can develop acutely an urticaria. The child can develop angioedema, so which is swelling of the underlying soft tissues, or the child can have aggravation of the atopic dermatitis. So these are the skin manifestations of IgE-mediated allergy. There can be GI manifestations like vomiting, colic, abdominal pain, diarrhea, or constipation. There can be respiratory manifestations like acute onset rhinorrhea, sneezing, cough, change in the pitch of the voice, development of hoarseness, loss of voice, stridor, or dyspnea. So all these things have been described, and they can be circulatory or cardiovascular collapse, which happens when the child develops an anaphylaxis. And these reactions could be triggered by ingestion of food, inhalation of food, and even skin contact has been postulated. Now, the history is quite important because unless until the history is very clear, there is no use of actually going on to the next step and evaluating a particular child. So, what were the exact symptoms, when they happened, how were the symptoms treated, and what was the timing of resolution of symptoms? So, usually a food allergy would happen acutely. So, a child consumed, for example, egg, and the child reacts immediately. So, the child develops an urticaria within 15 to 20 minutes, 30 minutes. The child was given an antihistamine, the child responded, and there was resolution of symptoms between an hour or so. So, this is what is meant by the timing. Now, if this child develops some vague symptoms on day 2, day 3, day 4, day 5, then it does not mean much, right? So the history has to correlate that this allergen was there in the environment at this particular time, the child has eaten this, and the child develops symptoms which are typical of food allergy symptoms during that interval. Now, the eliciting food allergens. So, which food induced the reaction, and is the allergen typical for age and country? So, as we know that in India we do not have a lot of nut allergy. So, if a child comes to you and says that my child has reacted to this, then the chances of this being a true allergy would be less as compared to a similar child presenting to in the UK, because the chances of food allergy to this allergen are significantly high. So we need to know that what are the common food allergies in our area, because the pre-test probability has to be high. Now, how long after the exposure the child develops? So IgE mediated reactions usually would happen within 15 to 30 minutes to maximum of 2 hours. So any reaction which appears late may not be actually related to a food allergy. Now, is the reaction reproducible? So the child has consumed a peanut today or an almond today. So something happens today, and he had consumed the same thing after a few days prior to that, but the reaction doesn't happen. So if it is a true food allergy, then the reaction has to be reproducible. It should happen every time when the child consumes the same food. Now, there can be differences if the food is processed or it is a raw food. And there's a slide on this later that because of processing of food, the proteins can change. So they change to a different protein, and the reactions to processed versus non-processed food or raw food could be different. So that is something which we need to know. So the child may react to egg which is not processed, but the child may not react to a baked egg product. Similarly, to milk versus a baked milk product, the child may not have an allergy to baked products. Right? What was the route of exposure? We need to know it is inhalational. It is eating that particular food. How much food allergen did the child have before reacting? Because some children will not have or will have a very minor reaction to a very small amount of food, but they might have a bad reaction if the amount of food increases, and this can be variable for different children. So there could be some children who may not tolerate even a drop of milk and might develop an anaphylaxis. Now, we also need to know the background of the child, that is there any other medical condition which we are dealing with? Does the child have associated asthma, atopic dermatitis, allergic rhinitis or conjunctivitis? Then there's a definite role of cofactors. So there are certain factors which increases the chances of this child developing a reaction. So the classical example is something known as exercise-induced anaphylaxis. Child eats a particular food, and if this child exercises within 30 minutes to 2 hours, then the child develops an anaphylaxis. But if the child does not exercise, then the child can tolerate the particular food. So the cofactors are certain things which can increase the chance child to develop an allergic reaction. It can be exercise, it can be drugs, it can be alcohol or something like this. Now, we also need to know the co-reactivity and the cross-reactivity. So can the child eat or tolerate the allergens which are cross-reactive? Uh, and there can be cross reactivity between pollens and food, and we'll talk about it. And there can be cross reactivity between food and latex as well. So, if a child can tolerate one particular nut, uh, but the child is actually having a problem with the other nut, then you're not confident that this child might be allergic, right? Because if this child is actually allergic, then he should be allergic or reacting to the cross-reactive products as well, right? And we also need to look at is the food allergy compromising the dietary intake, and how is the nutrition of the child going on, because you have to supplement this child. And we also need to know that if the child has actually followed the elimination diets previously, and what happened when this elimination diet was given to this child. Now, there are clinical syndromes with non-IgE related food allergies. So the phenotypes which I had shown you were with the IgE phenotypes which are known. Then there can be non-IgE phenotypes, which includes FPIES, which is a food protein induced enterocolitis syndrome, or proctocolitis or enteropathy. And these are usually seen in the setting of milk, but they can also be seen with soy, rice, wheat, and egg. So all these things are known. So proctocolitis basically would be there in a younger child, and the classical history would be blood in stool. So that is how a food protein induced enterocolitis presents. And I think everyone would have seen a child of CMPA presenting with blood in stool in this particular age. Uh, they can be breastfed children who have CMPA, because the mother might be taking cow's milk and it is transferred, but it is definitely more common in children who are on mixed feeding. Uh, Children can present with enteropathy, so they would present with a chronic diarrhea between 1 and 3 years of age. And FPIES is something which is which presents with repeated episodes of and repeated septicemia like episodes, and sometimes can be difficult to diagnose, but it is a severe form of non-IgE mediated food allergy. Now, once you have taken a good history and you feel that yes, this child might be allergic to a particular substance, then there is a definite role of confirming the food allergy, uh, because there can be non-specific reactions to food. So how do you determine the sensitization? So that is basically done with the help of allergy test. But before considering any allergy test, it is necessary to consider the clinical context to determine the pre-test probability, because the false positivity with food allergens seems to be quite high. So they can just be sensitized and they may not be truly allergic. And if you get into that situation, then there's an unnecessary avoidance of food. So to cite an example, you might get a child in your OPD, डॉक्टर साहब इसे बड़ी सारी चीज़ों से एलर्जी है, कैसे है, इसका आईजी लेवल हाई है, अच्छा और क्या हुआ है, इसका हमने ये स्क्रीनिंग टेस्ट करवाया था और इसमें देखो आप देखो 15 चीज़ों से एलर्जी आई है. So that is something which is quite common in the OPD. So you will find parents roaming around with a report which says that my child is allergic to cucumber, shimla mirch, wheat, egg, and so many things, and they would be avoiding these foods without any help. So that is precisely what I mean to say, that you need to have a pre-test probability in mind, which depends on the local circumstance, that this allergy is, what is the prevalence of this allergy in this setting, and what are the symptoms of this child, uh, uh, and why you want to do the test. Right, so the clinical history and the prevalence tells you about the pre-test probability, which is extremely important before you embark to any allergy test. Now, food and aeroallergens related to clinical presentation, age, and geographical location should be investigated, and we avoid identifying food allergens where sensitization is seen without clinical relevance, and that's quite important. So what test we have? So we have a skin prick test, as we had talked about in the last time. We have serum specific IgEs. The commonest available is an immunocap, which is readily available across all labs now. And there's something known as component resolved diagnostics, or CRD, which is still not launched in India. And there's a plan to launch by Thermo Fisher next year, but it has been launched in a lot of countries across the world. So the serum specific IgE or SPT, they're good to confirm or rule out involvement of IgE for food hypersensitivity. And it is also useful in assessment of co-sensitization or cross-sensitization to related food allergens. And I'll show you an example of this. But we also need to remember that a positive SPT alone is not enough to make a diagnosis of food allergy. So if you have a child where you, as I said, you find that a panel has been done and the child is allergic, or it shows sensitization to so many things, does not mean that the child is clinically allergic to that product. Now, if you're doing a skin prick test for food allergy, then there are a few things which everyone should know regarding the food allergens. Now, there can be a possible underrepresentation of minor allergens, or there can be an unstable allergen or an unstable allergens as far as the food goes, right? So there can be a very high false negative rate can occur. So which means the child is truly allergic. You do a reaction, you do a SPT, but you find that there is no reaction. So that is what is meant by a false negative reaction. Now that can happen because the allergens in the food may not be very stable, right? So once you're trying to make an extract out of the food and trying to do a test with that, this is a problem which can happen. And this is the reason why a lot of authorities recommend that you should use fresh foods in such situations. So supposingly a child is suspected to be allergic to kiwi or to banana or to a pineapple or to milk or to egg. So a lot of people would actually use fresh foods, and that is something known as a prick to prick test. So you prick the kiwi with the lancet so that the allergen of kiwi is there in the lancet, and then you prick the child with the same lancet and mark it as kiwi, and then you look at the reaction. So that is what is known as a prick to prick test. So we have to be careful that if you're testing it for a food allergen, a prick to prick test is something which should be done, and not just the extracts which are used or provided by the companies. The extracts are quite good if you're looking at aero allergens, but they're not very good if you're looking at food allergens. They're good for nuts, but they're not good for vegetables and fruits. Now, in the presence of a suggestive history, a negative SPT is to be interpreted with caution, because you might have a non-IgE mediated food allergy. So non-IgE mediated food allergies cannot be diagnosed with an SPT or a serum specific IgE. So that is something which is important. So you have to have in the back of the mind, am I dealing with an IgE mediated reaction or a non-IgE mediated reaction? So to say that this child has a proctocolitis and this child has a negative SPT to milk does not mean anything, because it is a non-IgE mediated reaction. Now, there can be situations when SPT and IgEs are inconclusive, then a component resolved diagnostic is something which can help. And I do understand it is not available today, but it is going to be available soon. And if there's a situation when the clinical history or SPT or IgEs are not highly predictive, then something which can confirm is an oral food challenge, and I'll talk about it. So this is an example. So these are aero allergens which we have tested. So dust mites, DF or dermatophagoids, fariny or pteronesias, and this is the histamine positive control, and this is the saline control, and this is dog, cat, cockroach, aspergillus, fumigatus and alternaria alternata, and these are the pollens which we have tested, again similar in the next two figures. So this is a child where there was a history of wheat-induced anaphylaxis, and there was a large reaction to wheat, which we found. Now there was a history that this child had consumed cashews twice. So in the form of a barfi. So this child was given cashews, and as soon as the child was given cashews, the child vomited twice. So we weren't very sure whether it is just a food aversion, the child did not like the taste and vomited, or it is actually a food allergy. So we told the parents that unless until we test him for the cashew, we don't give any more cashews, and we wait on it. Now, when we tested, we found a large reaction to cashew and pistachio. And so cashew and pistachio are of the same class. So if you look at the botany of these two products, and then they're highly cross reactive, and that is what we found. So this child had an IgE mediated food allergy to cashews and pistachio. It was a very large reaction which we could see, and also to egg. Now, can you predict whether this child is actually just sensitized or allergic? So, for example, uh, in the previous child, when we did an SPT, so if you have a reaction which is as large as this cashew or pistachio or egg, then does it mean that the child is just sensitized or the child is allergic? Well, if you have a significant history, then you know that yes, this child is truly allergic. But are there any cutoffs for the serum specific IgEs or the SPTs which tell us that above this cutoff we'll say that this child is allergic, and below this cutoff we'll say that this child is actually sensitized? So there is some data which is there for peanuts. So an SPT of more than 8 mm is considered to have a low sensitivity, but it is highly specific in most studies, and it is said that approximately 95% positive predictive value is there. And a peanut specific IgE of more than 15 kilounits per liter has a very high specificity of a PPV of more than 90%. We have limited data for the other tree nuts, again for more and of 8 mm cutoff for SPT and 15 mm cutoff for a serum specific IgE. Now, we do understand that these cutoffs have a low sensitivity, and therefore, if you have a lower Ig or SPT values, it must be interpreted with the clinical history to make a correct diagnosis. It is also to be remembered that the wheal size can guide you whether it is allergy or sensitization, but it cannot tell you the severity, which means it cannot tell you that what reaction is going to happen if the child has, for example, a 12 mm wheel. So is it if the child has a 20 mm wheel, then the reaction would be worse? No, it does not mean that. It just means that they are possibly allergic and not just sensitized, but the clinical severity is not predicted by the size of the wheel or the values of the serum specific IgEs. Now, components. So, for example, there are a lot of proteins in peanut. So, if a child is actually sensitized to ARA-H2, then it is confirmed that this child is actually allergic, because that is the protein which leads to allergy. And similarly, there are reports in cashews and hazelnuts as well. For rest of the nuts, we do not have a lot of data which is there. Now, the third is the elimination diet, which can be done to especially for the non-IgE variety, but sometimes for IgEs as well. Now we have to understand that the duration has to be no longer than necessary to achieve a significant relief of symptoms. So you don't do it for a very long time. So for IgE mediated reactions, it might be just 2 to 4 weeks. For non-IgE, it has to be longer, like 6 to 8 weeks. Now, if the effect of avoidance is limited, so supposingly you ask a parent to avoid milk in the diet of the child. Now, when you reevaluate this child, you have to carefully reevaluate the potential food allergens which might have been overlooked. So, is this child actually consuming milk in any other form? It might be paneer, it might be curd, it might be a cake, it might be a biscuit, or so on. So that is what is meant by carefully reevaluating the potential food allergens which might have been overlooked. Or you might be dealing with an additional food allergy. So for example, are you dealing with an additional egg allergy or soy allergy or so on, right? if there is no effect of avoidance and you're sure that the diet which you had recommended was fine and it has been properly followed, it means that this particular food is unlikely to be associated to the symptoms which they are reporting. And avoidance phase should always be followed by a planned reintroduction of the eliminated food uh, in a proper manner. Now, if the reaction has been minor, then you might do that at home. But if the reaction was something like an anaphylaxis, then obviously it has to be done in the hospital setting. Now, what are oral food challenge tests? So it is basically you're trying to replicate the food reaction which might have happened to the particular child. It can be used to confirm the diagnosis of food allergy if you aren't sure about it. It can be used to monitor food allergy, so and to prove oral tolerance to a given food. So what it means is that a child was allergic to milk. You have followed up this child for 6 to 12 months, and now you want to see whether this child is tolerant to milk or not. So usually what would be done is that you will do a serial SPT to see whether they are waned off, or a serum specific IgE. Once it reduces significantly, you would in a controlled setting give this child milk or egg or the particular substance you want to do in graded doses, so as to understand whether this child still is having a reaction or not. Now these food challenges could be open food challenge, so which means that everyone knows that you're giving milk or egg to the child. It can be single blind, so you know what you are giving, but the parent does not know, because there sometimes can be psychological symptoms, especially with older children. So I feel that once I take a particular product, I get tingling in my mouth, and there is some amount of diaphoresis which can happen. There can be some amount of tachycardia which can happen, and so on. So there can be a lot of subjective symptoms which comes in with food allergy. But you will not have uh, uh, things like urticarias, angioedemas, and all these things. But these subjective symptoms can develop if you're doing an oral food challenge. So there can be a single blind challenge, but there can be a double blind challenge as well, where you also don't know what the child is being given, and the child and the parents also do not know what is being given. So only the person who has prepared the meal knows whether this child has actually received the placebo, or this child actually has received the particular allergic food. So usually the single and the double blind challenges would be done only in research settings. They're difficult to do, difficult to prepare, and difficult to execute. In clinical practice, mainly open food challenges are done. Now, I don't want to go into a lot of details how challenges are performed, but something in brief, that uh, the choose which you actually choose should replicate the usual edible form which the child would eat. Make sure the food processing which has been done. So, are you testing for a raw egg versus a baked egg? Uh, what are you trying to test? If you're trying to test for a pollen food syndrome, uh, if you're trying to test for a fresh fruit or vegetable has to be used, because they can be heat labile. Uh, Choose a proper food matrix, because sometimes the extra ingredient might be creating a problem. So for example, if you use a muffin, if you're trying to look at, for example, egg, right? Now, if that muffin also contains milk, that can be a confounder, unless until you are sure that this child can tolerate the milk, right? Or if the muffin contains a nut, right? Then you don't know what this child is actually reacting to, if the reaction would happen. Then usually it is given in logrammatic doses, and there are charts available what amount of protein you want to give to a particular child, and usually 3 or 5 doses are given. There's something known as an initial dose and something known as a top dose of the child. If the child does not react within 2 hours of giving the top dose, then the child is said to have passed the particular reaction. Right. So just a small word about the special phenotypes which we were talking about. So there's something known as Food dependent exercise induced anaphylaxis, as I had said. So it is induced by exercise after food ingestion, but does not occur either after food or exercise alone. It is again IgE mediated, usually is induced by exercise within 2 hours of ingestion of food. Usually seen among adolescents and school-going children. Uh, it is sometimes it can be a bit difficult to diagnose, but usually you would test the food first. The child would be usually sensitized to a food, and then what you do is that you give that food and make the child exercise in front of you and see whether the child develops this particular reaction. So this is how it is done. So it is a food challenge followed by a food with an exercise challenge that would clinch the diagnosis. There's something known as an oral allergy syndrome. So the child is actually sensitized to a pollen, so which means the child is supposedly sensitized to a birch pollen. And there are few fruits which would cross react with the birch. And when this child consumes these fruits, vegetables, or legumes, the child will develop some oral manifestation in the form of urticarias, tingling in the mouth, or localized angioedemas. So this is what is usually seen. You need a good history, a prick to prick test, and sometimes might need an oral food challenge to come to a diagnosis. So what is the natural history of food allergies? So as I had said, there are few of the food allergies like peanut, tree nut, sesame, fish, shellfish, which actually would persist into adulthood. And there are certain food allergies which are more transient like milk, egg, soy, and wheat, which you would usually resolve. And that will help you to manage your children better and to counsel parents. So most children, or 80% or 90% of children, will actually outgrow by 8 or 10 years of age, and around 10% would be left after puberty. But for example, peanuts, not more than 20% would actually lose to have allergies, and mostly they would continue into adulthood. Now, how do you manage food allergies? So the long-term strategies include elimination diet, which is the cornerstone. There has to be a lot of education and risk assessment. There is a very small role of immunotherapy in food allergy at the moment. A very small role of anti-IgE or omalizumab. It is usually used if someone is trying to give immunotherapy to reduce the side effects of these immunotherapy. Then the challenges have to be done at regular interval to assess achievement of tolerance, and you're trying to deal with cofactors. Now, appropriate dietary avoidance is definitely the key. A sufficient elimination diet should be based on a formal allergy assessment, because you're trying to avoid that particular food which might be quite nutritious for the particular child. So there has to be a clear diagnosis, and unless until that has been done, you should not use elimination diet for therapeutic purposes. You might be using elimination diet for a diagnostic purposes for a limited period of time. That is different. Dietary counseling is a must, and regular monitoring of growth is a must, because a lot of children might falter in their growth. Now, there has to be a lot of education and risk assessment, because you need to tell parents what is to be avoided. You have to teach parents about reading food labels, because a lot of processed foods might have different ingredients, and sometimes food labeling may not be done properly, especially in developing countries where we do not have legislation on food labeling. Eating outdoor is again a problem, because sometimes you've ordered a particular food, you do not know what the contents in the food. So you've ordered something and it actually contains a nut which you were allergic to, or the child was allergic to, and you never knew that, and the child gets an allergic reaction in a restaurant. So they should know that. Then prevention in school is important, because some children will get meals in the school, or sometimes they might be sharing the tiffin with their friends, and they should know what they need to eat and what they do not need to eat. Then all children who have food allergies should have an allergy management plan, and I'll show you an allergy management plan which we have developed for our clinic. So this is an allergy action plan. So it tells you what is to be done for a particular reaction. So is it a mild or a moderate reaction? So for example, the child has swollen eyes, face, or lips. There is some tingling in the mouth, there's some hives, there's some abdominal pain or vomiting or sudden change in behavior. So this child needs an antihistamine. So what dose and which antihistamine is to be used? And the child and the parents have to be taught that these are the signs which tells you about a severe reaction, which is an anaphylaxis. So there can be airway signs, there can be breathing signs, and there can be impairment of consciousness. And what is to be done? So the child has to be laid down, and the child has to be given adrenaline. And we have customized this according to the Indian setting, because if you look at any allergy action plan from the Western world, it would talk about adrenaline auto injectors or EpiPen, which are hardly available in India, and they're extremely costly. And the problem is that they have a very small shelf life. So most people in India would make a pre-filled adrenaline syringe for for the patients, and they would usually give two of them. And usually the parents would be taught how to administer adrenaline into the outer thigh. So just a small word on oral immunotherapy. It is something which is coming up, but it is associated with a significant risk of adverse reactions, including anaphylaxis, and hence it is only for research purposes at the moment for uh, food allergies. We're not talking about air allergens at the moment. Then the oral food challenges, as I said, they have to be done on a regular basis to understand whether the child has developed tolerance or not. So just for an example, a child has an IgE mediated allergy to egg. You know that, yes, this allergy can pass off. So every 6 to 12 months, you would either do an SPT for egg only, or if the child is actually allergic to multiple products, then for those products only, see whether the SPT reaction of the serum IgE actually is waning. And once you have achieved that, you can do an oral food challenge to see whether the child actually responds or reacts to the particular food. So this is how the children with IgE mediated allergies would be followed up. If you know that the child is actually allergic to something which doesn't wane off, so the child is allergic to, for example, prawns, you know that there's a very limited chance of this child actually weaning off, then you might do an oral food challenge in 2-3 years or even longer. Now, heating is and processing is something which will convert sequential epitopes into conformational epitopes, and this is the reason why a lot of children might tolerate baked products, and that is most important with milk and egg. And it is important to know because it makes life quite easy if the child can take baked milk or baked egg, because baked milk and baked egg are actually present in a lot of preparations which children would be consuming. So for example, cakes, biscuits, muffins, and so on. So a lot of things actually have baked products. So if the child is not taking milk but can take baked things, then the life becomes quite easy. It is quite difficult to avoid baked products for children. And as I talked about cofactors, so look at exercise, NSAID, and the other things which might be leading to allergic reactions, because if you can withdraw the cofactors, if they are there, then the child may be able to tolerate a particular food, and the most common is exercise. Now, there are a lot of problems in developing countries as far as food allergies are concerned. There's poor public knowledge on food allergies. There's poor data on prevalence of food allergies. So I have not presented any prevalence data. Why? Because we do not have a lot of studies which are there from the Indian setup, especially from northern part of India. And it is mainly based on self-reporting and not properly allergy diagnosis or OFCs which are done. The SPT extracts are of poor quality. They may not be available for local foods. And serum specific IgE, most people are still using RAST, which is now outdated as compared to immunocaps. The gold standard is the oral food challenge, but there's poor availability of trained specialists who can actually do a food challenge for a particular child. And there are management issues like elimination diets could be difficult and frustrating, particularly for foods which are commonly used in the diets. So it's quite difficult to avoid wheat or egg or milk for a particular child. Then we have problems with legislations like inadequate food labeling. There's no legislations for restaurants and hotel to tell you that this food has this allergen, and if you're actually allergic, then you tell us upfront, and we'll manage that. And obviously the poor literacy levels. So just to summarize here, that food allergy is an upcoming and under-recognized problem in the developing countries, including India. Proper allergy testing should be done to confirm the diagnosis. Dietary counseling is important to maintain their nutrition. And there's a definite need to develop a food allergy service or a food allergy clinic in the hospital. So we have been doing skin prick testing. We have not done a lot of food challenges or drug challenges, but definitely that can be done. So thank you very much. And I'll just stop here. And if there are any questions, then we can take them.
Very good presentation, Ankit. One of the best as far as food allergy goes. I have never heard such a comprehensive, detailed presentation. Very interesting. Slightly long for this session. I think if we present somewhere, maybe we can break it into two.
Yes, sir.
बहुत लंबी काफी है. I mean, single-handedly. बाकी बढ़िया बहुत है. Very well done.
अपने यहाँ थोड़ा सा टाइम का इतना कंस्ट्रेंट नहीं होता, so I thought.
हाँ, नहीं कोई बात नहीं. It was good for us. I mean, but